A lot of us are excited about additional treatment options in metastatic prostate cancer and other tumor types, carcinoid and such. And actually, four of our practices have radiopharmaceutical programs. Others are trying to help answer that need. We know that again, access is an issue, and so we're all trying to come up with that solution. We're honored to have Dr. Scott Tagawa from New York Presbyterian Cornell, who's going to talk to us about kind of what are the right patients we're thinking about, and hopefully about a little bit about the future. Thank you for joining us.
Thank you very much for the invitation and introduction. Let me see here. So these are my disclosures. I'll leave that up for a second. So I think this is somewhat appropriate to come on the heels of the CAR-T discussion, because what I'm going to discuss are, generally speaking, non-off-the-shelf therapies that require some sort of accreditation, although I think the bar is much lower for these, particularly because most practices want to have access to the diagnostic side, the PET side. So I'm going to give a little bit of a background. It's going to include, I can't remember, 2 or 3 slides about prostate cancer background. I know that Umang spoke yesterday or the day before about prostate cancer in the landscape, but just to make sure we're all on the same page, because I think, actually don't even know, I should have polled the audience. I think we have a number of different backgrounds here. So this is not 100% exhaustive, but really the field in terms of what some people call theranostic, certainly in the field of therapeutic radiopharmaceuticals, iodine-131 is the clear starting point for us. We have a couple, or have/had a couple of beta-emitting palliative medications for painful bone metastasis. And then prostate cancer had the first, actually the first alpha emitter period, and the first solid tumor outside of thyroid to have something that improves survival in radium-223. Lutetium-177 dotatate came in for neuroendocrine pancreatic cancer. I almost always say neuroendocrine prostate cancer. So I'm proud of myself to say pancreatic cancer or upper GI tumors. And then what I'm going to really focus on is lutetium, the pivotide textratican. I'm going to say lutetium PSMA 617 because that's what I've been saying for a number of years. And you know, each one of these has a paired kind of an imaging. It's loose when we talk about bone, so bone scan is the imaging agent, but these are all paired in this kind of theranostic platform. That's what we're going to focus on. So the landscape for prostate cancer period from diagnosis through death sometimes. You can see at the far right, lutetium PSMA 617, that's where it falls right now per the available evidence and therefore the guidelines. I'm not going to go through this, but as I talk to patients, I go through different categories, in part so I don't forget to mention everything to the patient and their family. I would put this in the category of molecularly selected therapy, at least for now, because we are selecting based on a test, and in this case, it's a PET scan. So these can be complex therapies. Generally speaking, the people that administer these therapies are not the people that are following them on a day-to-day basis. There's some radiation oncologists that follow the patient throughout the treatment life cycle. But generally speaking, the people that deliver these therapies are not the people treating them. So I think that this is just true for kind of overall, but especially in something like this, I think that a multidisciplinary treatment team is not only needed, but I think is beneficial. And I would go ahead and expand this team through a lot of things, and you'll see flying in here. It doesn't have to be a dog. I happen to be a dog person, but it could be any sort of pet that's here. This is my bias that this is going to be in the patient's interest. So I'm going to the target that I'm going to talk about until the very end is PSMA, which stands for prostate-specific membrane antigen. I think most of you at least heard of it. You can see a quote from Neil Banner, who's in the top left, who invented the first diagnostic and therapeutic antibody that successfully targeted viable prostate cancer cells. Skip Heston to the right, they're both in New York, who discovered the gene. But it's a cell surface target that's not shed. So unlike PSA that goes into the blood, it's not shed. Prostate and prostate cancer restricted, but not only. So prostate specific is a misnomer. It is in the normal areas of the body, the luminal surfaces of the salivary and lacrimal glands, brush border of the small intestine, and proximal renal tubules. The reason that the luminal expression is important because large antibodies can't get there, but small molecules can. It's also expressed on the neovasculature of virtually all solid tumors, somewhere between 80 to 90%. PSMA expression is related more or less inversely to the AR pathway. So you give testosterone, PSMA goes down, you block testosterone, it goes up, loosely speaking. Also loosely speaking, when we lose AR, so small cell for instance, lower chance of having PSMA there. The initial pathology studies said it's there 100% of the time. We use this as a very sensitive imaging tool, so we think that, well, if we can't see it, it's not there because PSMA is the most sensitive, including this, quote, non-metastatic or M0 CRPC disease state. But we know that there's heterogeneity. There's intra and intertumoral heterogeneity. Can you play the bottom left? So there are different applications. I'm going to talk about really radiopharmaceuticals, but if you can play there. So, looking at a cell surface target, and I just describe these to patients as locks and keys. We can attach a drug. We can attach different things. CAR T cells is another approach where it's going to be specific to the cell. These are generally speaking internalized. Can you play the other one? In the body, this is a bone scan. So in the body, this will demonstrate the specificity. I've cut out, this is an antibody which is cleared through the reticular endothelial system, which would normally light up. I've taken that out, but we can see here it's relatively specific. And over days, winds there and sits there for days, and you can see certain areas that are lit up on the bone scan, which are non-tumor, so they don't have PSMA and they're arthritis, but the areas that are tumor are there. So this is a publication from the Prostate Cancer Foundation of all the different things they funded, kind of bragging about themselves, including PSMA, and many of us forget that the first PSMA imaging was FDA approved in 1996, so an antibody. That antibody binds the internal domain of PSMA, so it can't get into a live cell. That was the problem. But this is not so new, but it is new to have it one that actually works. This talk is not focused on imaging, but imaging is part of it. So there are dozens of small molecules in the clinic used as standard of care in different countries or in clinical trials in the United States. But the two main ones are gallium-68 PSMA-11, different versions of that, and F18 DCF-PYL. So those are the two that are FDA approved and available to many of us, not quite all of us yet, but I suspect most of you will have some availability. There are a number of different uses. The two ends of this are what I would say the main uses are. So initial staging, biochemical relapse, and then target predictions, what we're going to really talk about. I think there's things that are in between. We're literally right now working on what's called Working Group 4 to describe how this should be done for clinical trials. We know that radiation works for prostate cancer and other diseases. We can shoot it in, we can put it in, and now we can infuse it with the two therapeutic radionuclides that lead to overall survival advantages. So this is already described, but basically there's three components. I'm not going to talk so much about the linkers, but there's the effector molecules. So generally speaking, these are going to be betas or alphas. There's also Algés that are out there in terms of discovery and development. And then some of these we can image the same molecule, like lutetium, and some of them require a different molecule for imaging. And then there's the targeting vehicle. Generally speaking, there's small and large, and they have different properties. The top one is the approved agent, but you can see there's three that are in various phase 3 clinical trials, and this is not an exhaustive list. There's a number of other ones that are in phase 1 and phase 2, and hope to get into phase 3 in the coming years. So this is an emerging field just for one target. Two things to say. So see what we can treat. So this lends itself to case reports, but the field really started anecdotally, that we can see something, we treat, and then we do an image and we can see. This happens to be a couple of our own anecdotes where, patient had a number of therapies, got treated, looks better, number of therapies, including radioligand therapy, and then got better with another type of thing. So a lot of anecdotes. This was the first, quote, good publication, 145 sequential patients across a dozen centers. in Germany. But I really use this to show that the problem with the retrospective data, that a third of them in the waterfall plot, a third of them didn't make the waterfall plot because they didn't have the PSA available. You get treated, you don't come back, there's no PSA. And you can see the low adverse event rate. Now what happens when you ask 6 or 8 weeks later, anything happen? No, you're okay, and it doesn't get attributed or documented. Then the Australians came out with the first prospective data set, and then at a talk I gave in 2019, I was very happy to say, not only do we have prospective data, we have completed accrual on 2 prospective randomized trials. I'm going to talk about, I think you know at least about vision and probably about therapy, but in pre-treated metastatic CRPC, imaging selected versus a control. And 2021, these were presented and published in high-impact journals. The vision study with the alternative primary endpoints that were both positive, overall survival and radiographic progression-free survival, and therapy head-to-head against cabazitaxel improved all of the endpoints pretty much, PSA response, progression-free survival, better tolerability overall, and no detriment to overall survival. So I think you know all that, so I'm not going to spend so much time, but I'm happy to answer questions. There are adverse events. These are from vision. I put them into categories, so constitutional, such as fatigue, myelosuppression, and then different ends of parts of the GI tract, which are on target for PSMA, but off tumor, dry mouth because of salivary glands, and hitting the small intestine, nausea and vomiting. There is a target in the kidney. Luckily, we have not seen any significant renal failure, but it's early. If anything, this is expected to be a late effect, and most patients don't live 5 years when they have metastatic CRPC, so we'll see. Despite the increase in adverse events, overall quality of life is either improved or sustained, so the time to a detriment in overall quality of life with FACT-P or pain is improved despite the adverse event profiles. So you can see kind of the unmet needs that we have here. Not everyone responds. I do think that to simplify everything, I think dose, and I'm defining that as dose to tumor. So that is how much radioactivity do we inject plus how much target is there and how much stays there. That's what I think makes up dose. And then on the patient, you know, how radiosensitive. There's a lot of factors there. How radiosensitive is it? So with what we have, you know, I think we need to optimize the dosing schedule, optimize the patient population. That's what I was asked to talk about, so I'm going to focus there. Really focusing on the current labeled indications, pre-treated, but there's a number of clinical trials. So 4 clinical trials with 3 different drugs in the chemo-naive MCRPC disease state, and 2 randomized trials, one phase 2 and one phase 3, at initial diagnosis, initial metastatic non-castrate disease, in combination with standard therapy, one with AR, one with docetaxel. And then getting to more powerful agents, I think, is something I'm very excited about. So to take a step back, who was included in the trials? So the way that VISION was designed was essentially analogous to the way that ALSYMPCA was designed. That was the trial that got radium approved. So they had everything that was known to be a benefit to them, which could include, you know, radium, could include CPL-T, could include PARP inhibitors, et cetera. There was, if they were those were thought to be a benefit to them, they were supposed to have that first, with the minimum of 1 AR and 1 taxane. That was the minimum to get in. And then they were treated with best standard of care alone or best standard of care plus lutetium PSMA-617. Therapy was a little bit earlier. All they needed to have was docetaxel before. As it turned out, 9 out of 10 happened to have an AR pathway inhibitor such as abiraterone or enzalutamide, but that was not required for the trial. And they had to have a minimum PSA of 20 because they had a PSA endpoint. The other differences here, and actually therapy, I'll remind everyone, gave a higher radioactivity dose. The imaging selection was looser for vision, and that's when we say someone's PSMA positive, most of the time today we're going to use the vision criteria, which was having at least 1 lesion with uptake greater than liver. So that was 19 out of 20. So we eliminate about 5% in this heavily pretreated patient population. Lost another 8% or so because there could not be a soft tissue area with uptake less than liver. So about 12.5% were excluded based on imaging. Therapy had a higher bar, had a much higher PSMA, and they also did FDG PET. They couldn't have any areas that were positive on FDG and negative on PSMA, so they took out 28%. So when we say that lutetium PSMA 617 is better than cabazitaxel, the caveats are it's a phase 2, but the other caveats are that it was heavily selected or more heavily selected by imaging and a higher dose than we give, about 15% higher in terms of radioactivity dose than standardly based on vision. We have looked at imaging, and there has been an association retrospectively with imaging. Both of these randomized trials looked at it in greater detail. So this was done by Phil Kuo. He wasn't allowed to present at ASCO, so Andy Armstrong presented for him. But looking at the baseline PET parameters only in the investigational group. The control is not here yet. So we can't look at predictive capability. But you can see here, basically, when there's a plus, S means significant, plus means a positive association, negative means a negative association. With the bottom part, in terms of where are the tumors, it's absence of. So this can be a little bit confusing, but I'll walk you through the main points. So by quartiles of SUV average or SUV mean, this is not something that is available to us. This is a sophisticated analysis of the imaging. So I get a PSMA PET at Cornell. This is not available to me. So even academic centers do not have it available. It's got to be something that, well, I think in the long run, it's really going to be AI. But when we do look at that, and pay attention to the numbers a little bit, just this happened to occur at around 10, there's a difference in terms of RPFS as well as OS. Those other curves, that doesn't mean that those are not benefiting over not getting it. It just means there's a bigger benefit and some prognostic information here. When we look at PSMA PET for where is the cancer, this really validates Halabi, et cetera, about if you have cancer in bone versus not, it's better not to have it in bone. If you have cancer in liver versus not, it's better not to have it in liver. That's basically what this showed. Lymph node only is the best. Therapy looked at both arms. So looked at both the cabazitaxel arm as well as the lutetium PSMA arm. And therefore, they were actually able to look at both predictive capabilities and prognostic capabilities. And basically, this is the predictive capabilities based on their primary endpoint of PSA response. Much brighter PSMA PET, an association with response for the lutetium PSMA 617, not so much with cabazitaxel. So this is something that does look to be predictive, again, not widely available to us in the clinic. FDG, as we have known from before, prognostic. So and this is overall FDG tumor volume, it's better to have less uptake and less volume, which makes sense. That was both for PSA as well as PFS. A UCLA-led group that was a US, Germany retrospective analysis. What about those patients that are treated with lutetium PSMA that don't meet the vision criteria for PSMA PET positivity? They do better if they meet the criteria, but what you can see in the table to the bottom left in the blue is that the PSA response rate is 1 out of 5, that 50%, and 2 out of 5 have some PSA reduction. So to me, on a practical basis, because of the reasonable, I think, tolerability profile, if someone has a weak PSMA PET and literally has no options, no clinical trials, you can say what you want about the cost. It's something I would think about treating, but that's not the optimal patient. Each one of our prospective trials, every one of them, the lowest quartile had the lower chance of working, but they all had some evidence of response. So we would say the same thing as we published in the overall data set. Imaging probably makes sense. What about toxicity? So the patients coming in met criteria, as you can see here. So performance status 0 to 2. You can see their heme parameters. The creatinine is interesting. So these are OR. So basically creatinine less than 2 or a calculated clearance greater than 50. Most people got in with a creatinine less than 2. And if you calculate for a 70-ish-year-old man, a lot of them are going to be less than 50. We don't see a lot of renal toxicity, like I said, but this is renally cleared. So there's going to be a higher radioactivity amount being delivered to other sites if it's cleared slower. So something we'll look at. And then is there a sink effect? A lot of cancer, more is going to go there with less to other organs. So that's another aspect about the pre-treatment PET and treating them. Super scans were excluded, but retrospective data says it's safe. So in summary, I would say that PSMA imaging is a reasonable biomarker. One of the advantages of imaging is you can think of this kind of like cell-free DNA, that we look at the total body, except cell-free DNA, you can't look at the individual lesions. We can look at heterogeneity with imaging. Disadvantage is it's at one moment in time, and I'm going to get to combinations briefly, that can change. So I already showed that slide. Antibodies and small molecules are different biodistribution. Alphas and betas are different. We've seen these wonderful case reports with the alphas. You can look at the prior treatment and PSA values, really ablated everything. Ablated some of the PSMA positive normal areas. There's no more salivary glands on the slide, right? Anecdotes, again, retrospectively, and then the first prospective trial was presented last year at ASCO, hopefully published soon. So we are getting into these more potent therapies. I wouldn't say that these have the level of potency of CAR T cells, but similarly in terms of solid tumors, picking the right target I think is important, because these very potent effector molecules in the wrong place could be harmful. So this particular drug is moving forward in a number of different trials, and there's a number of different targeted alphas that are not only PSMA, that are in prospective phase 1 and 2 trials. Combinations, so there's a number that are out there. The main thing that I wanted, you don't have to memorize this, I'm happy to share slides down the line, but I really wanted to point out is there are implications with combination therapy. So they can change the target. So we give abiraterone and enzalutamide, generally speaking, PSMA goes up, but the tumor might respond. So by imaging, it may go down because there's less tumor there. So the surviving cells have more PSMA, but there's less volume there. And volume is important, particularly for the beta emitters, because of their path length. They also can affect uptake and retention. So we know that, at least preclinically, if we give an antibody, well, let me put this a different way. The small molecule enters a cell and is excreted pretty rapidly. If it's in the lymph node, it goes to the neighboring cell node, not a big deal. In the bone, it may wash away. If you have the antibody there, it stays. So we can change that, and then some of the drugs radiosensitize. And that's why we give hormonal therapy with external beam. So there can be differences in the overall efficacy and toxicity profile with combinations. So in summary, I would say that this is a validated target. We have antibodies and peptides. Since we can see, quote, everything with a PSMA PET, are we going to cure? Probably not because of heterogeneity, but I do have hope for earlier disease states and combinations. And then I think that the field is ripe to really move forward. I don't know that we're at only 3%, like the CAR Ts, 97% of eligible patients are not receiving it. We might be there, but I do think there's going to be much more rapid growth as more centers come in, and eventually we're going to develop more targets. So I think that this is going to be a more common day-to-day type of therapy. And all the research was done by a lot of collaborators and less by me. Thank you very much.
Awesome. Dr. Sikas.
Scott, how can we expand the clinical trials program for these compounds? I've tried to send patients to you and there's a long line. How can we expand it throughout the country, you think?
I think it's already expanded. So, this was a lot of initially academic work, and a lot of that was restricted to New York, either across the street from each other. And that's just the way that the field was. I think there's a lot more, and that was kind of in-house, our own things. Now that pharma's involved, there's a lot more that are out there. A lot of them are still it's like the question about why did CAR T start with the transplanters? That's who's kind of comfortable with that. I do think it's more, and they are distributed across the country, including phase 3s. So I do think it's more widely available, but still restricted to centers who the pharma companies are comfortable with them doing it. So I think it's thousands of fold more available in terms of trials, but I think it's really looking at clinicaltrials.gov, looking at all the different sites, and then finding one that's amenable for patient travel.
I think I'd pivot a little bit and ask even about not on clinical trials, but access to this drug in general. So we know that, I'd have to, a little controversial, academic centers failed our patients when it came to GI neuroendocrine tumors. When you have wait lists of 6 months or longer, long travel, I think we've discussed this with cellular therapy. There are patients who die before being treated. Now that's a tumor that's much slower, and this, as you already pointed out, these patients have fairly short overall survivals. And so are academic centers expanding access? And then the second one is there's a real payment issue, I think. So even in those groups within our practice who've been able to gear up and prepare, it's really a cost sink when you think about what reimbursement is in the community setting versus hospital settings or academic centers.
So I can't really speak to the reimbursement in a community setting because I don't know. But all new, I would consider this a drug, all new drugs, before there are codes, it's difficult. And we started this with patients with Medicare, just assuming we're going to get paid in the next couple of years. Being able to absorb the cost in a center. But now, there are, it does look to be profitable. But in terms of, originally PetNet had 180 sites throughout the country for lutetium dotatate, and those were the initial ones that could, in theory, just flip a switch and have access to this. The issue, I think, is twofold. So one, I think many more sites are interested, because it's prostate cancer, a much more common disease, and they all want to have PET. So if you can have PET, it's similar in terms of just expanding the radionuclide label, site licensure. And it just, more patients, more dollars, I think, coming into that. That's the incentive. At the same time, unfortunately, overall availability from Novartis is low. So everything commercially comes from Italy. The Jersey site has been up and running for a long time. That's only used for clinical trials until the FDA clears that site, which in theory is going to be in the next 4 or 5 months. So once that opens, then I think not only academic centers, but other centers will have more access. And I think those are happening together.
We're running it in our
It's going to expand, I think, relatively quickly. But the other barrier is also, it's not the urologist or medical oncologist giving us, it's radiation oncology or nuclear medicine.
Awesome. Thank you. Other questions? Awesome. Thank you for your time and your travel.